Thank you, Praveen. And to start with the next session, I would like to invite Dr. Sunil Dadich, Dr. Sudipto Dhar, Dr. Devender Singh, and Dr. Sunil Jain as a chairperson. And I request them to invite moderator and the panelists for the panel discussion. And Dr. Praveen, you can take 10 minutes extra because we have saved 20 minutes. So this panel discussion can go for 50 minutes. That is acceptable.
Okay, Dr.
Yeah. Good morning, Dr. Rajesh and all others. And may I take this pleasure to invite Praveer along with his team, the panelists, to start the panel discussion on EUS-guided tissue acquisition. So Praveer, please, you can invite your panelists and start the proceedings.
So can you see my slides?
Yes, we can see your slides.
Okay, so we have a very important topic to discuss for this panel discussion, and this is EUS-guided tissue acquisition. And for this, we have a very eminent panelist, Professor Peter Willman from Denmark, Dongwon from Korea, Dr. Kida from Japan, Dr. Amol Bapai, and Dr. Ankit Dalal from India. So just to start this discussion, we just need to know the common indications for EUS-FNA, which are pancreatic biliary tumor, subepithelial lesions, liver lesions, abdominal lymphadenopathy, and mediastinal lymphadenopathy. So any lesion which is adjacent to the GI tract, we can safely do an EUS-FNA. However, just to list the few contraindications for performing EUS-FNA, these are similar to that of endoscopic examination: cardiac with respiratory instability, perforated viscous, non-fasting patient, patient on anticoagulant or antiplatelet therapy, large vessel or duct interposition, metastatic lesion with primary mass interposition, and where you think that EUS-FNA will not alter subsequent management, you should not be doing it. So to begin with, we have a case. This is a 35 female presented with pain in abdomen for 3 months. LFT was normal. CT showed a mass in the body of pancreas. There is a non-dilated bile duct and the pancreatic duct. EUS was done, the video of which I'll be playing. So following this EUS, you can see there is a large mass occupying the body of the pancreas, very huge mass occupying the body of the pancreas in a young patient who is asymptomatic, is having pain in abdomen and LFT normal. So Professor Peter Willman, this patient needs tissue. How do you intend to achieve it? Percutaneous or EUS guided, and why?
Yeah, I think there are some considerations here. First of all, let me thank for the invitation to be part of this panel. Tissue acquisition, EUS guided, has been a great part of my life, and I'm glad to be here together with all of you. There are some consideration. First of all, there is a local preference, and secondly, there is also consideration on the route, at least, where you want to do your biopsy. There's no doubt in my mind if a lesion is in reach within the range of gut that is resected during a Whipple procedure, I would not be in doubt. It should be EUS guided for sure. And it has been shown that even if you do EUS guided biopsy pre-operative in patients with Whipple procedures or not, there's no difference in mortality between these two groups. So I know we can do it without hurting patients, and that's of course very important. The question is now, this is in the body of the pancreas, and the question is now, where should we do a biopsy, and should we do a biopsy? That's another issue, because 35 years. You know, it's not a straightforward. There's no straightforward answer, and that's of course why you are discussing this. And you know, 35 years old, and if it is resectable, I would say that in northern part of Europe, we would probably not do a biopsy. We would probably go direct for surgery. But in Denmark, practice has changed. And as long as at least you can do the route where that is resected during a Whipple, it's acceptable to do a biopsy. But I learned through visits in India that we have quite different patients. I still recall my visit in New Delhi, where I got a patient that had a lesion, and I said, this is 100% a cancer. And I realized that you had a lot of problems with TB, which I've only seen one case of TB during my 40 years of practice. So this was quite a new eye-opener to me. And, you know, therefore, this could also be TB in this patient. And therefore, I think, of course, it is important. And most of your patients have antigens or antibodies towards TB, even in case of TB. So I would say you should do a biopsy in this young man, which unusual 35 year. It's not that frequent that these patients have pancreatic cancer. So I would go for biopsy.
Dr. Rai,
Thank you, Dr.
May I add?
Yeah, please, go ahead.
Yeah, I'm Dongwan. Yeah, it's very nice to see the iconic figures here, Dr. Peter Billman, and also all my friends. It's my real pleasure to join this meeting. If I add my personal thought on this case, yes, there are some group of doctors who are actually not recommending FNA or percutaneous or EUS guided because the lesion is located in the body and tail, it is resectable, then they think direct surgery is better. Yes, it can be a good approach, but sometimes we realized that after resection, we thought this is should be resected lesion, but it was a surgical specimen occasionally shows the autoimmune pancreatitis or other types of benign tumor. And in this case, 35-year-old female, I think the probability of malignancy, such as pancreatic cancer, is very low. So my personal preference, even though it is located in the body and tail, I think we should do US-guided FNA. I don't agree with if the facility, it depends on the situation, institutional situations, but in our hospital, definitely US-guided, no percutaneous biopsy for pancreatic lesions these days. This is my personal opinion.
Yeah, can I comment? I fully agree, and of course, good to see you.
Yes, nice to see you.
It's you know, the autoimmune pancreatitis. So FNA or FNB. For that, I would say FNB. So I would do FNB, and there are studies now that definitely shows that FNB is better for autoimmune pancreatitis than FNA.
And also, this is young female, so I think still there is possibility of solid pseudopapular neoplasm because it's frequent in young age female. Yes.
Yeah.
Yeah, so just to add to it, I think in India, we still would go ahead since a young patient with these presentation, relatively asymptomatic, just pain in abdomen, considering, as has been pointed out, that the incidence of TB is very high, many of these patients turn out to be tuberculosis. So, Dr. Peter Wilman, if you intend to do acquired tissue, would you want a FNA or an FNB?
Yeah, yes, I already mentioned that. That is, I think this is also part of my lecture after this session. And, there are more and more evidence that when we need more tissue, we need to do FNB. And for this, which potentially can be an autoimmune pancreatitis, I think we should choose an FNB needle. It definitely gives much more tissue, and this is required in this patient. In case that it is a cancer lesion, I think it's still wise to do an FNB, because we probably in our institute would also go for molecular analysis of this disease.
So,
If I may add,
yeah, Dr. Amol, please.
yeah, just in a minute. If we are suspecting cancer, then probably an FNA very often is adequate. But if we are suspecting autoimmune pancreatitis or a benign disorder, then probably FNB is better. So for benign diseases, we probably need more tissue, and FNB is superior to that. So.
Yeah. So I think there are some distinct advantages between FNA and FNB. I'm sure Dr. Wilman will cover that in this lecture. But just to point out a few, with FNB, you can choose not to have an on-site pathologist. Your procedure time is decreased. You get core tissue, for which you can use for immunohistochemistry and other reasons. So that may be a reason to do an FNB over FNA. So, Dr. Dongwon, if we intend to do a biopsy, now we know that we have needles of different designs. So, which design needle would you choose and why?
Dongwon, you are muted. Dongwon, you need to unmute yourself.
Oh, sorry.
Don't worry.
Can you hear me now?
Yes.
Yes.
Yes. These are the different designs of FNB needle. In Korea, we have Procore, reverse bevel also, but we don't have charcoal, but we have acquired needle. And also, we have forward facing bevel, Procore needle from Olympus, and we don't have top gain, this type of needle. So in Korea, we need to decide whether side cut biopsy or direct forward procuring biopsy needle. When you compare the forward and the side cut needle, my personal preference is forward cutting. It is because less, the amount of tissue we can get is, from my experience, is better. But it depends on how you do it and who are the operator. But my personal preference is, at the current moment, is acquire needle from Boston. And I'm very happy with the yield of this needle, because generally we do just 2-3 passes, and we are adding not in Korea, nobody uses rolls. We think it is a redundant procedure, and takes time and also manpower, and not cost effective. We are using macroscopic on-site evaluation after acquired needle biopsy. And if you see macroscopic visible core, or sometimes you can see bloody tissue granules, then 2 or 3 passes is generally good enough. And the yield from my experience is more than 96% and 97%. So I'm very happy with these results. So definitely my preference is, I've never used the Charcot needle, so I don't know the experience, but at the current moment, acquire needle shows very good results in Korea. And many people inside Korea are changing from Procore to acquire. I think this is a little delicate statement. There are companies, but I'm adding my personal experience. Professor Kida.
Yeah. Can I make a comment from Japan?
Please.
Hello.
Dr. Kida, please.
Okay. And first of all, I am come from Japan. Don't want to come from the Korea. First slide is wrong. Okay. And from the Japanese endoscopies, now we can use the Procore new and old one, and also the Procore Acquire and Charcot. And I never use the Top Gain. And according to the Japanese consensus, maybe Japanese opinion, and at the moment, I prefer the Acquire needle first. And I use several times of the Charcot, but from my experience, not so good result. I cannot get not so big tissues, and I cannot make a comment on the Top Gain. And Procore is, I think, at the moment not so. I think the Procore is not so superior to the FNA. So and this is very delicate comment, I think.
There are company people behind, I think.
Yeah.
Professor, would you like to make a comment?
Do you refer to me? Yes?
Yeah.
Yes. Yeah. Which needle to use? Again, I will cover it in my lecture and give you the scientific background, but to make the answer short, I fully agree with the discussion. Front cut needles or crown cut needles are 100% better if you want lots of tissue. There are studies showing that they take double as longer tissue course than does the Procore needle or FNA needles. So front cut needles are the best. Charcot Acquire, there are also technical issues that should be considered. The front cut needles has a tendency, if you do at least more than 2 passes, it's difficult to get them passing through the tissue and into tumors. And you now and then have to take a new needle. This is not the case with FNA. So this is something also that I consider, at least, and sometimes, or very rare, I would say, but it has happened that I have to take an FNA instead because I really cannot get it into a bony heart tumor.
Okay. So, Dr. Dongwon, the company people come and tell us that this needle is excellent because it is made of nitinol or stainless steel or chromium cobalt. So what's your take on that? Which material and how does this influence the yield of the tissue, which is your primary goal?
That part sometimes can affect the yield, but only in angulated portion. When the lesion is located in an angulated portion and a difficult position, then the needles which can show some flexibility, and also after one test, the stainless, if the needle tip is bended, it's going to be difficult to use again. But other than that, I think most of the needle shows very good performance. So I am not very much discriminative on this material wise.
Yeah, I think some comment, I don't know whether we have studies on that, but Nitinol needles are considered to be more flexible, especially if we want to take a lesion, say, from the uncinate process of the pancreas. I don't think we have much evidence to talk about that. So, Professor Kida, in case, when will you prefer, normally, as the literature is evolving, now we have more and more evidence of FNB compared to FNA. When will you prefer FNA over FNB? In what scenarios?
Yeah.
Or still you are using FNA for all your cases and FNB only occasionally?
So, according to our data at the moment, using the acquired needle, we can get the bigger sample, bigger tissue compared to the other FNA needles. And therefore, in our department, we at first we preference is FNB, acquired needle first. But of course, concerning about the puncturability, so FNB needle is not so good enough to compare to the FNA needle, such as the EZ Shot 3. Concerning of the puncturability, the EZ Shot 3 is the best at the moment. So, and also concerning about the size of the needle, in our department, we started the 22 gauge, the FNB needle in our department. So, and of course, in some cases, it is very difficult to puncture the needle, especially the small and also the uncinate process and other small SMT. And such occasion, we prefer the FNA needles. So this is our strategy.
Okay, so I think what you have mentioned is that for all cases, you resort to 22 gauge FNB needle. Is that right, Professor Kida?
Yes.
Okay, so Dr. Willman, you think the same?
You know, I think you should, it's not as simple just either one or the other one. It's a matter of reading the clinical history very carefully and what's needed. And it requires actually that you are a clinician with a good experience. I think if the matter is it cancer or not? So metastatic disease, is it a lymph node with a possible malignancy from a known primary tumor? Then I think FNA is sufficient. If this in any way could stimulate the discussion whether we should do genetic analysis to make more tailored therapy, oncological therapy for the patients, I would go for FNB. But yeah, in my practice, more and more tissue is needed, at least for pancreatic tumors. And for those, it's in most cases FNB that we use.
Yeah. So Dr. Ankit, would you like to make a comment?
Yeah, so I think I agree with him. So you have to look at the clinical picture. If the patient has a high suspicion of malignancy, an FNA should suffice. But if you are looking at clinically something like a lymphoma or a submucosal tumor where you need a differential between a GIST or a leiomyoma or a neuroendocrine tumor, that's when you would need more tissue, which will help you get molecular diagnosis, immunohistochemistry, which can then help in further management. But if you're looking at a pure pancreatic cancer, if the clinical suspicion is high, I think an FNA would suffice, especially if you have decent experience and decent your center has good tissue adequacy over time and a high volume center, and FNA, performing an FNA in those situations should be adequate.
Dr. Amol, would you like to make a comment?
Well, I can say that, whenever, as I mentioned, when we are suspecting cancer, then probably with the exception of a lymphoma, very often an FNA is adequate. But unless we want to do some genetic markers on that, we don't do that very often in India, as I must say, as they do it in Japan or in the other countries. But probably if they're doing genetic markers, then we'll need an FNB. But otherwise, for benign diseases, or whenever I'm suspecting a benign disease, or even for lymph nodes, I would prefer to do an FNB rather than an FNA.
I think especially in our country where tuberculosis is high, we need more tissue whenever we are sampling maybe lymph nodes or suspicious masses, wherein you need more tissue for culture and for other markers.
Yeah, and also, Praveen, as you've put there on the slide also, FNB needles are more expensive than FNA needles. So whenever we are thinking of doing interventional procedures or, just aspiration, then we don't really need the FNB needle. So we should go with an FNA needle because it will save cost to the patient. So that's definitely there. Uncinate, I agree, unless you can use a 25 gauge FNB needle, but then that the acquirer has the ability to do that now. So that is there now.
See, the reason that I'm spending time on this particular slide is because as I reviewed the literature and we have new evidences coming up, what I could understand is that if you want a single needle doing all the job, though it's slightly costly, you should be going for FNB. So this is why I wanted to have the opinion of each and every one that we still are using FNA needle for some specific indications. And if you come to the size of the needle, as has been mentioned by Professor Kida, that he prefers to use 22 gauge FNB needle. And if you see the various studies, 8 randomized controlled trials and 4 meta-analysis, which don't suggest there is much difference between the gauge of the needle and the adequacy of the material or the diagnostic accuracy. So ESG guidelines this 2017 suggests that for routine sampling of solid masses and lymph nodes, you can do a 25 gauge or a 22 gauge FNA needle. What they suggest is FNA and FNB needles are equally recommended. This is what ESG 2017 suggests. They suggest to use FNB needle if the intention is to obtain a core, and it can be 19 gauge FNB or a 19 gauge FNB, FNA, and a 22 gauge FNB. So Dr. Amol, once you decide to do a tissue acquisition with an FNA needle, I will talk of first. Would like to use suction or without suction, and with or without stillant?
Yeah. So suction, absolutely, I know. I would hardly ever use a suction, meaning practically I don't think I remember the last time I used suction. Rarely, if you've got a really hard mass in the pancreas and your first 2 or 3 passes are completely dry, then maybe you could use a little bit of suction on your third pass. That is a possibility, but otherwise no suction. Regarding a stylet, I usually keep a stylet within the needle when I puncture, because it helps me to clean the tip of the needle sometimes when I'm going through the mucosa. But then I withdraw the stylet, and then I do the pass without the stylet in any case. So that is how I do it. If the lesion is in an angulated position where getting the needle in is difficult, in those situations I will remove the stylet and go in without the stylet, because that gives my needle much more flexibility. So that is how I do it. There's another technique which is called the wet suction. Now, I am not too much of a fan of a wet suction. I tried doing it for a few, on a very few occasions, but I really never found too much merit in it, and then I just stopped it. I don't have any actual experience more than 4 or 5 cases, but then we just stopped doing it because it was a little bit messy. That's what we thought. And but yeah, meaning no suction and stylet only for puncture. That is what my recommendation would be.
Yeah, I think most of us would agree to it that for suction, it's usually for pancreatic masses, maybe after the first pass when you don't have much material, then you can apply suction. For all other cases, possibly it's best to go without suction. And I think we have evidence for that. And for stillet also, I don't think anyone uses the stillet. As far as the technique of suction is concerned, about standard wet suction and stillet slow pull technique, I don't think here also we have sufficient evidence to recommend either wet suction or slow pull technique, as has been pointed out by Dr. Amol. Any other comment? Yeah, Dr.
Yes, yes, please. You know, it's. I think when we are discussing stylet or no stylet, one forget the reason why the stylet was there. I invented the handle, the procedure, and at that time I had to build in all the safety possible, because I've punctured a lot of endoscopes, I can tell you, in the beginning. and that was not very pleasant. And so I think when Amol, you say that that you don't need the stylet, I fully agree. We don't need the stylet. But I think don't forget that people who are not as experienced as we are, I think it is wise to say, please keep the stylet there until you have the needle out of the endoscope. For training, I think
I totally agree.
is important.
Firman.
Right, I will agree to that, Professor. Meaning, definitely. As I said, I usually keep the stylet in until I puncture and then I pull it out. That's my policy, because it also helps to clean the tip of the needle sometimes.
Yeah, I think the point has been well made and has been suggested by ESG again. They don't recommend for or against the use of stillet, and they recommend using the needle slit for US guided sampling with FNB needles. This is what the recommendation is. Dr. Ankit, about the sampling technique, we have a technique known as fanning technique and the normal standard technique. So do you resort to fanning? If yes, why?
So yeah, we standardly perform the fanning technique when doing FNAs. So there was this one randomized study by Dr. Varadarajulu group which showed that by fanning, which is you are targeting different areas of the lesion by using your up-down wheel or your elevator, you can get increased tissue, you have reduced passes, and the diagnostic accuracy is comparatively better compared to just the standard technique. So yeah, we would recommend doing the fanning technique for tissue acquisition.
Yeah, then the other part is, if once you complete the FNA, you do ROSE, or you choose not to do a ROSE.
So our center, we don't have the ROSE facility. So ROSE obviously provides theoretical advantages if your center has it, but very limited centers in Asia have the facility for ROSE. So obviously with ROSE, you have better diagnostic accuracy, you require decreased passes, the procedural time can be reduced, and you have less side effects perhaps. But it's controversial, as I think Professor Dong Won also mentioned, that perhaps ROSE is probably becoming redundant with the use of FNBs and the macroscopic evaluation. So yes, ROSE does help if you have it, fine, but it includes a lot of extra manpower. It's not cost effective. If in the future you have facilities for maybe telecytopathology, or you train the endosonographers themselves to have a look at the slides after an FNA to assess for tissue adequacy and diagnosis, that would be good. But at the present moment, at least in our scenario, I don't think ROSE offers us a lot. It is time consuming, and very few centers have it.
So, Dr. Willman, I would like to know your comment, because the statement that has been made that ROSE is now redundant. Do you agree to that? Professor Willman.
What do you mean that it's not necessary?
Yeah.
Is that, yeah, I fully agree, and I mean it's nice to have ROSE. We don't. So what we do is we look at the microscopic aspirate, and then I mean, in many cases you can see that you have actually enough tissue. But if you look at the scientific results, I think that as far as I believe, then there, in the beginning, people said there is ROSE should be implemented in your practice, but I think meta-analysis have questioned this, and I think that more and more most centers do not have ROSE. In my practice, I say no, but if you can afford it, then it's nice to have a pathologist directly at your site saying you have enough now for the diagnosis.
So, Dr.
Can I comment?
Yeah, please.
Okay. And according to my opinion, the ROSE is good for the learning phase. In this institution, maybe they can use the ROSE, but after some experience, ROSE is not necessary. And also we have already recently published the stereoscopic on-site evaluation. And that is very good, very easy. Just see the size of the white core. Then more than the 11 millimeter, that is enough for the tissue evaluation. Then that is more. This is similar to the modes. Then for the 22 gauge, the tissue is very thin. Therefore, we employ the stereoscope scope.
I agree with Professor Kida. I think in inexperienced hands, maybe ROSE would benefit. You will get more confidence about your sampling technique. And once you gain that experience, perhaps you can do without ROSE.
Well, Pravir, I think, I have a little bit different opinion. We do use ROSE at our center. We have the facility, and our pathology department is just one floor away. So the residents can come up, the DNB residents can come up for the evaluation on site very easily. And because it's an in-house facility, there is no added cost to the patient as well, except for a single time investment of a microscope in our unit, which we did about many years ago. And I would say one thing, that yes, I agree that with the FNB needles and with increasing experience, probably the role of ROSE is going down. But when we also have trainees, when we are allowing our trainees to do the first pass, and then we are taking in the second pass and all these things, it is important that they also understand how the pass is taken and why, how the slides are being made and all these things. So I think if it's possible, it should be used. It's not mandatory, but it is a good addition to have if you have the facility and you can do it. That's the way I would put it.
Yeah, so one of the other point, I think that once you're repeating an FNA, possibly it may be worthwhile to have a ROSE in place, because you don't want to have a negative tissue again. So that may be one of the reasons where you want to have that. So Dr. Ankit, what is a cell block?
So cell block, usually you express your aspirate materials in a specialized solution, and then it's processed with centrifugation and then addition of thrombin and plasmin to form a clot, which can be then fixed, and then you can have actual processing like a histopathology. You can do H&E staining. So this, with an aspirate, you can have preserved tissue architecture. You can do immunostaining or immunocytochemistry for as you mentioned, lesions like a GIST or a lymphoma. So yes, with an aspirate FNA sample, a cell block gives you additional information whenever you require. But with the, if you want such information, I think you would prefer to do an FNB rather than do an FNA and perform a cell block. That would be the practical way of doing it.
So, would you like to do this cell block and in each and every FNA that you do?
No, I think in specialized situations, I mean, as I said, most of our sampling now at our center is an FNB sample now. So only rarely are we performing FNAs for certain lesions, difficult lesions, maybe uncinate lesions. So yeah, we are moving towards FNB. So the cell block, again, if you want additional information, is beneficial.
Professor Dongwong,
Yes.
when you take an FNA, would you like to make 1 or 2 extra passes and take material for cell block in all patients?
When we do FNA,
Yes.
I was waiting my turn to comment on that. Yes, previously we discussed that if it is suspected pancreatic cancer, then FNA is enough. If not, benign lesions, FNB, yes. Yes, theoretically, it is, I mean, very wise. But when we think about real clinical situation, it's much more complex. I think, yes, it is pancreatic cancer, FNA is enough. But like this case, this is 35-year-old female patient showing a mass in the body, and the pre-FNA probability of pancreatic cancer is not very high. So even though we are suspecting pancreatic cancer in real situations, in some cases, pre-FNA probability of pancreatic cancer is very high. In those cases, we can use FNA needle. But in many cases, there are overlaps. So in those cases, I think instead of insisting FNA, I think it's better to go with FNB needle. So these days, I'm using most of the times FNB needle instead of FNA. And I am using FNA for cyst ablation or cystic fluid aspiration or interventional use to guide wire use, or very rarely, because of FNB needle has a little blunt end compared to FNA needle. So in some special situations, we can use that. But for regarding to the question, cell block, we tried many times in our center. Because initially when we started FNA, the yield was not very good and some patients did not show any yield. So we insisted. We put everything on the cell block fluid and then we sent to the pathology and they did centrifuge. They tried to look at it, but the result was not, the result was not good because we are looking only the patient initial FNA was not successful. If the cell block shows good results, FNA also shows good results. That was our experience. So we seldom use cell block in our center.
Okay. So I think the next point that I want to cover is that if you're not using on-site, rapid on-site examination, then how many passes do you make?
That was when we focused on our study. When we use FNB needle, we checked macroscopic on-site evaluation, especially 2 parts. One is macroscopic visible core, and the other one is blood tissue granule. Sometimes we cannot find white tissue core, but there are a lot of blood, and we are using filter paper. And the filter paper absorbs all the blood material, so it can expose tissue granules. So we call it a bloody tissue granule. So when we look, when we find macroscopic visible core or blood tissue granule, at least 2 passes, then we thought it is enough. So when we analyzed our data, we just did 2 or 3 passes. The average is in between 2 or 3.
So I think perfectly said. So this is what the guidelines 2017 ESG suggest. For an FNA, you need 3 to 4 passes, and for an FNA needle, you just need 2 to 3 passes, so that it saves upon your time. So coming to the few different scenarios, US guided acquisition in a pancreatic cystic tumor. So we'll be taking only brief about all these different situations. So Dr. Peter, if we have a pancreatic cystic lesion, you want to acquire tissue, which needle would you choose? And what test will you do in the cyst fluid to make a diagnosis?
Yeah, it's if it is necessary to obtain tissue. We have recently published this January in Endoscopy our prospective study on microbiopsy through the needle microbiopsy of cystic lesions, pancreatic lesions. And I think this is the preferable test today, should you require a tissue diagnosis. I briefly touched on that also in my presentation. As for which kind of fluid analysis we like, then I would say we do routinely CEA, we do routinely CA99, we do routinely glucose evaluation, which is a recent test that in the differentiation between mucinous versus non-mucinous probably is the most sensitive test. So glucose. Sometimes we also do amylase, but when it comes to differentiating between a non-mucinous or a mucinous cyst, then I think CEA is and glucose is the ones to prefer.
Okay. Thank you, Dr. Williams, for that. So what are the, just for the beginners, you want to know exactly how to do the procedure. So these are the, Dr. Dongwon would just tell those points of doing the FNA.
I think it is well summarized on this slide. Verify the indication. If it is unnecessary FNA, better not to try it. It is costly, and also it can very rarely, although it's rare, it can create complication. Localize the lesion and the position of the echo endoscope. When we try to look at the pancreas head lesion, we can locate the lesion from the stoma, and also we can locate the lesion in D2, D3, and also we can locate the same lesion in D1 balloon wedged position. So in same lesion, we can, delineate the lesion in several different points, but try to the best angle. I think even though it is visible, if the scope tip is too much angulated, I think for the beginners, it's not a good position to do directly FNA. But I think for beginners, it's difficult to locate the same lesion in several different points. So delineation technique is very important before going to the FNA. Choose the correct needle. In my case, FNB needle. Insert FNB needle into the echo endoscope with the stylet initially, as Professor Spielman mentioned, to prevent the damage of instrumental channel of echo endoscope, and also the tip of sometimes the elevator can be stuck. Position the lesion in the needle face. Yes, generally not in the 2-3 o'clock position. Generally 7-8 o'clock position is a relatively linear, straightforward direction, but you can use some angles of tip of echo endoscope first, and then final adjustment with the elevator a little bit. Elevator can adjust the angle, but if we start elevator first, then it's not a good idea because it makes a lot of resistance. puncture the lesion and move the needle within the lesion. Yes, this is important. When it is, especially it is malignant lesion, it's better to grab the tissue inside the lesion to remove any possibility of seeding and also the contamination of other tissues like gut or normal pancreatic tissue or surrounding tissue. After puncture, and withdraw the needle and process the aspirate. Yes, we need to do that. Prepare the needle for subsequent pass. Yes, these are basics for FNA steps. Yeah.
Dr. Praveer, can we conclude?
I think 2 more minutes will conclude. So, Dr. Dongwon, how to increase the yield in patients with mass in the setting of chronic pancreatitis? I think very brief answer.
I think it's very difficult because chronic pancreatitis is fibrotic hard mass. So better to use not FNA, FNB needle. But even though we are trying to do FNB, I think the yield may be low compared to pancreatic cancer.
Okay, so I think Dr. Kida,
Yes.
for a few words just about subepithelial lesion. Would you choose an FNA or FNB needle? And will you do immunohistochemistry always in a subepithelial lesion?
Yeah. So in order to do the immunohistochemistry, of course, we prefer the FNB needle, even the very small region. And in our department, and for the small region, we prefer the forward viewing echo endoscope with hood. That we catch the submucosal region by the hood, then fix the target region, then we can make the FNB needle, even the target is small. So, it's okay?
Yeah. Dr. Amol, tips for sampling in patients with autoimmune pancreatitis. Just 2 or 3 points that you need to want to highlight.
Right. We need to do an FNB, not an FNA, and a 22 gauge needle, and otherwise a 19 gauge FNA. If you've only got an FNA needle, make sure you don't hit the pancreatic duct. So identify the pancreatic duct, and your needle trajectory should be away from the pancreatic duct, and preferably target the head region if the head is involved. If you feel that it is involved, if there's only a segmental involvement, then of course you have to target that area. You can't help that. I mean, that's it. And yes, I agree that rectal endomethacin may be used, particularly if you suspect that you've hit the duct, then you have to use the rectal endomethacin. But otherwise, also it may be a good idea to use rectal endomethacin to avoid pancreatitis, a flare.
Thank you, Dr. Amol, for that. So I think we are running short of time. We have exceeded by 2 minutes right now. Dr. Ankit, just position and the needle size for a lesion in the uncinate process.
Yeah, so because of acute angulation and a transduodenal route, you can have increased resistance fixing the needle. So always better to have a short scope position. You shorten the scope to make sure that the needle fixes properly. You can ask an assistant to keep the scope stable and use a smaller needle, like you mentioned, a 25 gauge needle, which has increased flexibility because the positioning of the lesion can be slightly towards the right of your screen, wherein ideally you would want the lesion to be in the center and to the slight left. So use a smaller needle with increased flexibility, use a short position. That would help.
Yeah, so we wanted to discuss about future, I think, but because of paucity of time, I'll just put up the concluding slides. US guided tissue acquisition is preferred over percutaneous, considering the fact that the risk of needle seeding is less. US guided tissue acquisition is best performed with a 22 gauge FNB needle using fanning technique. Again, some ifs and buts there. Rows of EUS further enhances diagnostic adequacy of more than 95% if done. Tissue specimens are best processed as surgical specimens. Mass in chronic pancreatitis, you need to do an FNB. Supplement that with elastography, contrast, and rows if needed. In autoimmune pancreatitis, tissue acquisition is done from head of the pancreas to avoid pancreatic duct. In uncinate mass lesions, 20 gauge, 25 gauge FNB needle may be preferred. Thank you. I would like to thank all the panelists for their very lively participation and helping for the panel discussion. Thank you.
Thank you.